appendiceal malignancies. So most of this has already been covered by the pathologist, the radiologist, the medical oncologist, and by Aditi. So I'll just try to put together these ones. So what we must remember is most of the appendiceal malignancies are discovered incidentally, except the ones that present as a pseudomyxoma, usually when patient is operated for an appendicitis or as an incidental finding during radiological imaging done for something else. So the pathology has already been described. I just want to ask the pathologist one question. So the TNM stages, the WHO classifies appendicular adenocarcinomas as mucinous signature cell and the others, that is a colorectal type. So we do come across patients who present with a large right iliac fossa mass. We assume it is a cecal malignancy. Colonoscopy is normal, but we go ahead with a hemicolectomy. Final report comes as an adenocarcinoma, colorectal phenotype, but we are not sure whether it is appendiceal or cecal. Is there any way to differentiate an appendiceal adenocarcinoma from a colorectal type?
Actually, no, because even on immunohistochemistry, appendiceal adenocarcinomas are going to express SADB2, and the colorectal would also express SADB2. I think it's the morphological and gross appearance of the tumor. If the epicenter of the tumor, careful gross examination of the specimen would tell you, because not morphology or IHC, because appendix can also have pancreaticobiliary and colorectal type of adenocarcinomas with the same immunophenotype. So when grossing, if the epicenter of the tumor is in appendix and then it is going in cecum, it needs years of experience in handling the specimens. One can say with confidence that this is an appendicular adenocarcinoma. If the epicenter is in the cecum, like the tumor is more of a cecum and going in ascending colon, terminal ileum, and appendix is not so involved on macroscopic examination, one can say that this is coming from cecum. At the same time, one has to know that if it's a very advanced tumor which is involving appendix, cecum, going up, going down, it would be impossible. So one just has to take some call and say.
So it's probably just a question of splitting hairs, because surgically I don't think it is going to make a difference in the management. And as far as the medical oncologist is concerned, again, it is not going to make a difference in the management. Okay. Yes, Aditi. Yeah, that is with peritoneal disease.
Yes.
Yeah.
But you cannot tell whether it's the appendix or the.
So that is where. But again, you'll still not really be able to say whether it is arising from the appendix or from the cecum.
I think. Yeah. Somewhere along the line, the colonoscopy findings are also going to guide you, unless there is obvious infiltration of the cecal mucosa. If you see that the cecal mucosa is normal, then it's very unlikely to be a cecal malignancy going on to the appendix as well.
More business, I think we can comment on more towards appendix. Intestinal type, I think more it's highly confusing.
Yeah. So this is the colorectal phenotype, which is not a mucinous.
See, actually, this is kind of a hair splitting, because as long as we are not talking of LAMs, so we are talking of adenocarcinomas, and one has to know that it is essentially same morphology and immunophenotype. Appendix can also be involved in a non-mucinous adenocarcinoma. It can be involved in a mucinous also. So as people are rightly saying, it's the essential epicenter. And in some percentages of the cases, it would be impossible.
The slide changer is not working. Okay. So the TNM classification, the latest edition has introduced some changes in the appendix, mainly the three-tiered grading system, and as was already mentioned, an in situ category for LAMN, and renaming of goblet cells as goblet cell adenocarcinoma instead of carcinoids, and the splitting of the metastatic disease into M1A and M1B. Now, so if you look at an incidental appendicular neoplasm, I'm sure we would have come across this scenario where appendicectomy is done for something else, and then suddenly you discover that it is not a benign tumor at all. So what is your thought process as a surgeon? Vivek or Shishir, one of you can probably answer. What would you consider in an incidental appendicular neoplasm that is going to decide what to do next?
Probably this patient will be referred by some general surgeon when this report comes. So first of all, I would like to subject this blocks to further confirmation by our pathologist. Also, we'll have a talk with the surgeon who has operated this patient and to give proper intraoperative picture of this whole abdomen, and as well as whether there was any deposits elsewhere. And also would like to do some form of imaging in the form of a CT scan, baseline CT scan, and some tumor markers, CEA, at least.
Anything else, Vivek?
We would definitely like to add a colonoscopy as well in this patient at this point in time. You would review the biopsy. Probably if it says clear-cut appendicular carcinoma, the need for review would become less, but it would still be good to review those blocks. But then rest I would just totally agree.
Yeah, so anything else? You talked about the histology, the slide review, the details from the surgeon, but most often you're not going to get the details of the rest of the abdomen because probably the surgeon would have just gone and done an appendicectomy and come out. So anything else that will help you decide your management, whether
so
the location of the tumor?
You have tried to, the location of the tumor and what were the operative, and some bit of it would be like intraoperative findings, whatever is documented basically, whether the appendix was perforated or not at the time of surgery, and this is what you would try to figure out from the surgeon, and whether and from the findings as well. And as you rightly said, peritoneal disease and extent they wouldn't have even considered, because generally they wouldn't have thought of a malignancy.
Exactly.
And by and large, quite often in these situations you know that they would just have mentioned some periappendiceal fluid or some periappendiceal pus. You really won't know what exactly was
one of the most important things probably is the perforation, whether the tumor is, the appendix has perforated.
Margin status.
Exactly, yeah.
And as well as T stage. If you are happy with the pathologist, it's okay, we can go ahead with the further workup. If we are not happy with the T stage or by the pathology report, definitely we will ask for slide or block review. And as well as the type of the...
Because if you look at the consensus guidelines that Aditi had referred to by the Eurocan, they almost all the categories they divide into whether it is a perforated appendix or a non-perforated appendix. So I think that information is very important. And perforation just doesn't mean that the appendix has ruptured. I think the pathologist has an important role to play, whether the tumor has come out of the appendix, whether it is a T4A tumor or not.
Serosal involvement.
Yeah. So let us just go through a few case scenarios. This was a lady who had a history of partial nephrectomy for RCC in 2017. On routine follow-up was detected to have a mucocele of the appendix on a routine follow-up CT scan. So I think the radiologist had mentioned that this kind of a calcification that you see generally tends to point towards a more benign kind of appendiceal neoplasm, isn't it? Like an LAMN or...
Yes, sir. So you can see there is a tubular structure with an eccentric calcification towards the right lateral wall. And as you have already mentioned that so we can see there is a mucosal with an eccentric calcification, and there is no definite any periappendiceal fat standing. So considering this lesion on the first image, LMN is the first differential diagnosis. Yeah. And I don't think such kind of a large appendicolith can cause such presentation with this. So
most likely we would think
yes,
it is
yes,
probably an LAMN. Yeah, okay. So how would you manage this patient when you see a asymptomatic mucocele of the appendix?
So by and large, most of these patients, unless there is a contraindication to surgery based on age or very, very significant comorbid conditions, most of these patients would be offered surgery. In which case you would do a lot of patient counseling, because the options at the time of surgery, if you have a big mucocele, you know that it is densely adherent to the cecal wall, then you know that the chances of you being able to take it out with the appendicectomy alone is going to be a bit tricky, because the most important thing, as Dr. already pointed out was that it is important not to rupture this appendix. And so you would be like the options on table which you would discuss pre-op with the patient as well would be just ranging from just an appendectomy to a right hemicolectomy with a cytoreduction and HIPEC depending on what you find intraoperatively.
So would you go in for a laparoscopic approach or an open approach, Dr. Sishur?
Looking to this CT scan, probably if I think that diagnostic laparoscopy is justified, and if there is a peritoneal disease in the abdomen, then yes, I would directly convert it into an open surgery.
Okay, so this patient underwent a diagnostic laparoscopy. There was no evidence of disease elsewhere. The entire appendix was distended till the base. There was no mucinous material on the surface of the appendix. So we proceeded to an open appendicectomy. We removed a cuff of the cecum just to get a margin at the base. Initial biopsy report was an intramucosal adenocarcinoma. I really don't know what that means. But then subsequently it was reviewed by a senior pathologist with much more experience in appendicular neoplasm. I'm sorry if you're not able to read it. So the final report was a HAMN. So to the pathologist, is it possible to misdiagnose a HAMN as something else?
Can you please come back to the question?
Yes. Is it possible to misdiagnose an HAMN pathologically as something else? If in this, it was first reported as an intramucosal adenocarcinoma by a junior pathologist with not much of experience.
See, actually, HAMN is a very rare condition. And HAMN versus an adenocarcinoma, it can be misdiagnosed if one doesn't pay attention to the pattern of invasion. It is essentially the pattern of invasion which discerns the two. So one has to pay attention, and here they have said vesicular nuclei. I was just trying to read that. They haven't really mentioned the pattern of invasion anywhere.
They said no invasion in here.
Where?
Yeah,
No invasion means they are talking of first biopsy said intramucosal. What I mean by pattern of invasion is in HAMN, the concept is that cytology and architecture would be same as an adenocarcinoma, but the pattern of invasion is not pushing, is pushing. Whereas if it's an adenocarcinoma, the pattern of invasion would be infiltrative. So what they mean by no invasion is it's not going beyond the muscularis mucosa, which the previous pathologist said intramucosal.
My concept of differentiating between LAM and HAMN was that they are both the same, except HAMN has got more features of cytological atypia.
Cytological and architectural atypia, correct. The way we discern HAMN from an adenocarcinoma is the pattern of invasion. It's not the depth of invasion. Because both HAMN, LAMN and an adenocarcinoma primarily both the LAMN and HAMN, they have to obliterate muscularis mucosa. One cannot say that it is an intramucosal LAMN or HAMN, yes. Number one. No, even HAMN. See, LAMN and HAMN, when you say appendiceal mucinous neoplasm, the definition is not on the depth of invasion. It is the pattern of invasion. Okay. So HAMN, one can never say it's an intramucosal HAMN, because intramucosal means it's just limited to lamina propria. And by definition, the appendiceal mucinous neoplasms have to obliterate muscularis mucosa, which is further away from lamina propria.
Yeah, so just
here,
taking it forward.
They have said no invasion because the previous pathologist has said intramucosal, so they are just supporting.
Yeah.
But
okay, so now let's just move forward. HAMN, you kept saying it is quite rare, but
very rare, very rare.
We're now coming across much more number of HAMNs. Is it probably because pathologists are not aware of this entity?
Correct.
Yeah.
It is because probably the pathologists don't know that HAMN is not high-grade mucinous carcinoma. It is the pattern of invasion.
So what would you do for this patient? Now you have a patient with an appendicectomy done for a mucocele. Finally, it has come out as a HAMN. You have only done an appendicectomy with the cuff of the cecum. There is no other evidence of peritoneal disease.
So most likely you would observe this patient and just follow up the patient.
Would the other surgeons agree with this?
Yeah, if the tumor markers are fine and there is no evidence of any disease, yes, we can closely follow up this patient.
You would agree with that?
observations.
Okay, so since this was probably the first case of HAMN that we had encountered a while back, at that time there was hardly any literature on what to do with patients with HAMN. So I wrote to the expert in management of appendiceal malignancies, Brendan Moran and Basingstoke. Now they have a policy of doing a prophylactic CRS and HIPEC for all high-grade appendiceal neoplasms that has been incidentally diagnosed. So this is what he told me, that you could go ahead with a complete cytoreduction, that is doing an omentectomy, right hemicolectomy, do a BSO if she is postmenopausal, and do a right parietal peritonectomy. But he also said you could probably even observe because your base is free. So you could observe. So there are two options here.
Yes, so probably after 6 months I will do a repeat diagnostic lab and then take it forward.
You would want to do a diagnostic lab?
At 6 months.
Why would you want to do that?
Just see whether it has progressed to disease.
But isn't that such a very short interval to progress for a HAMN without any other evidence of disease?
I think,
I mean, okay, your point is taken. You would want to find out early metastatic disease and tackle it, fine. But
somewhere along the line, we have to understand and accept the fact that our understanding of picking up limited peritoneal disease by any investigation short of a diagnostic laparoscopy is really limited. At the same time, we have to understand that what are we going to do at laparoscopy if we find very limited disease. But yes, if you find limited disease, you would definitely be going ahead with a surgery which you pick up the disease.
Would the radiologist agree with that? Would an MR, repeated MR pick up early peritoneal recurrence?
I'll go for MR peritoneum first. The good quality MR peritoneum.
So that
Yes,
so this is what we did. We discussed the option of going ahead with the second surgery and doing a CRS and HIPEC. Patient was not keen on doing that, so we just decided to keep her on close follow-up, and she agreed to be on close follow-up with a 6-monthly CT, and recently she came back for review, and so far there is no evidence of peritoneal disease. So this is the paper that he sent me to read. With their protocol of doing a prophylactic CRS HIPEC in all high-grade appendiceal tumors, they had published, they had analyzed their results and published 62 patients. What they found that in these patients, in the absence of any radiological evidence of peritoneal disease, peritoneal metastasis was much more common than nodal metastasis. In fact, 57 patients had incidentally detected peritoneal disease just because they did a cytoreductive surgery as a prophylaxis, whereas only 15% had nodal metastasis. So they believe that all such patients with high-grade appendiceal tumors should undergo a prophylactic CRS and HIPEC. Of course, this is their thought. The numbers are not very great, 62 patients, and of those only very few were HAMN, just 3 or 4 were HAMN. But this is some food for thought that high-grade appendiceal tumors tend to have more of peritoneal disease than nodal metastasis.
You have just 2.4% nodal metastasis.
Yes.
Good idea too.
So I think we will skip this in the interest of time. Now again, 2 other patients, just to show the difference in the management. This 62-year-old lady underwent an appendicectomy elsewhere for suspected appendicitis, and it was reported that intraoperatively there was a hugely dilated appendix with pus and inflammation, and the biopsy was adenocarcinoma, which was situated 3 centimeters away from the base of the appendix. When she came to us, we reviewed the slide. It was a mucin-secreting adenocarcinoma grade 2. It was reported as a PT3, tumor going up to the subserosa. CA was normal. The CT showed significant ileocholic nodes with no peritoneal disease or ascites. Can you please change to the next slide? Yeah, so then she underwent a laparotomy. There was a large nodal mass along the ileocholic vessels. So we did a right hemicolectomy, omentectomy, and a HIPEC. So she had node positive disease. 4 out of 13 ileocholic nodes showed tumor. She subsequently went on to receive adjuvant chemotherapy, and 7 years later she was all right. Now I'll show you another patient.
So what does the literature say about the support of, like in this patient you found some nodules, but they were all negative on frozen section. The benefit of adding HIPEC in this situation?
Yeah, I'll just come to that. So this was another similar patient who underwent appendicectomy in 2017. It was reported as a mucin secreting adenocarcinoma at the base. This is a 3 centimeter tumor. Slide review showed mucin secreting adenocarcinoma with signet-ring cells. It was reported as a PT2. The CT scan that we did after the patient came to us did not show any evidence of peritoneal disease. Her tumor markers were pretty much normal. There was no evidence of any enlarged nodes. Yeah, so we did an ileocecal resection with omentectomy. We did not do a hemicolectomy. We did not do a HIPEC. 5 nodes were removed in the specimen from the mesoappendix. They were all negative. We did not offer any adjuvant treatment. Patient was on follow-up. 5 years since the time of surgery, she was free of disease. So 2 more or less similar presentations. One patient presenting with ileocholic nodal metastasis. We had to do a right hemicolectomy. Another patient, there was no metastasis in the nodes. Both were mucin secreting adenocarcinoma. In one we did a right hemicolectomy, in one we did not do a right hemicolectomy. Those patients were doing fine. So how do you decide when to do a right hemicolectomy, when to do CRS and HIPEC in a patient who has a mucin secreting adenocarcinoma or an adenocarcinoma, non-mucin secreting adenocarcinoma in the appendix?
So for mucinous adenocarcinoma, probably doing CRS and prophylactic HIPEC is our institute policy. And in this case where there are signet ring cells, I think probably adding adjuvant chemotherapy, medical oncologist consultation would also be helpful in this patient. It is fine that patient is doing good, but
yeah, this probably may be an anecdotal incidence without any chemotherapy. But see, you need to understand that you cannot call this a signet ring cell carcinoma. The pathologist has only said there are a few signet ring cells. Like what was pointed out in the lecture, you need to have at least 50% of signet ring cells to call it a signet ring cell carcinoma. So probably just the presence of a few signet ring cells may not upgrade it and make the prognosis worse. So is that your practice? You do a hemicolectomy and the CRS
no,
always?
we would just do a hemicolectomy or mentectomy, and probably that's it. Unless we find some peritoneal deposits, we would generally stop short of doing a HIPEC at this point in time in this patient. Dr. Aditi, you want to add something there?
Nodal metastasis. Focal disease in the peritoneum rather than in the nodes. Yeah.
For peritoneal disease and not for nodal disease. So
Yeah.
I would say operating definitely. HIPEC again, it depends on the patient. It's patient to
Yeah, please
The
go.
question was, what is the indication for right hemicolectomy?
Right hemicolectomy and indication for HIPEC.
Actually, there is no standard guidelines regarding
Exactly.
for right hemicolectomy. But what the consensus is, but in the previous case, there was absolute indication because of
Yeah, she had
nodes.
obvious enlarged nodes on the
She
CT
has,
scan, so we had no other option.
As well as without any nodes, only grade 2 adenocarcinoma, appendiceal adenocarcinoma. I think consensus is everyone will go to even the.
Yeah, so
without any-
I put up these 3
Here
cases.
there is what you have written is, there is a tumor at the base,
Yes.
which is quite large, 3 into 1.5 centimeters. So probably he requires that clearance.
That's what the
you know.
size is.
We have
not
done an
the criteria.
ileocecal resection.
Right. So no, what he says that you don't need appendicectomy. In this case, it is
No, he said
required.
you don't need hemicolectomy.
I mean,
Hemicolectomy, we are.
but some resection is definitely required.
Yeah, yes,
Yes,
sir. That,
Right.
Consensus is go for right hemicolectomy in all adenocarcinoma.
So
for
that is the reason I put up these 3 slides. You know, the consensus is based on quite weak evidence. You know, we had a patient with a HAMN who supposedly thought to have a high incidence of occult peritoneal disease, who has survived for almost 3 years or more with just a very limited surgery. And you have another patient with a mucinous adenocarcinoma with signature cells who have only had a ileocecal resection without any adjuvant chemotherapy and has survived for 5 years. So what we need to understand is we are still a little bit shaky on the literature support.
Yeah, I think if you look back at the paper that you showed just few slides back, we don't have a control arm there.
We don't.
That is where we don't have a control arm there, and that's why probably we have these scenarios where not having done a HIPEC or anything has also resulted in good survival. But then yes, it does seem to make sense that if you got a perforated appendix, then the chances that this patient is going to have occult peritoneal disease or peritoneal failures is going to be high. Whether if we treat them early, we'll just get that lead time bias, or the patient is going to get a survival benefit, we don't know.
Exactly. So this is
Ram, my question would be, how, you know, when you are inside the OT with this kind of a case, what makes you think that limited ileocolic resection is what you are going to do and not right hemicolectomy? Because ultimately for us the morbidity is not going to increase. You are doing omentectomy also. So how do you really choose that, on what basis? Because as we see is that only 5 lymph nodes are removed. We may not be concerned about it, but at the same time...
basically 3 things. I would look at the imaging before going in, whether that shows any enlarged nodes along the ileocolic pedicle. I would look at the tumor markers, and then intraoperatively I would again palpate the ileocolic pedicle, and if there are any suspicious enlarged nodes, I would remove them and send them for frozen section. In the absence of all these, I would just probably do a ileocecal resection. But if the tumor markers are enlarged, or as in the second case where CT itself showed enlarged pericolic nodes, or if intraoperatively I could detect enlarged nodes and if the FS comes as positive, then I will probably go for a hemicolectomy.
Preferably which tumor marker, sir? Is it we should decide the tumor marker, elevation of tumor marker for surgical decision?
It is not the sole deciding criteria. I mean, this is what I take into account. High CEA, you cannot expect the CEA is 30 with this clinical scenario. Then I would probably think that I need to do a little bit more than
residual disease will be there.
Yeah. So these are the guidelines or the consensus statement in HAMN where they've said in the absence of perforation, you could consider a right hemicolectomy and you could probably do a CRS HIPEC, although the strength of recommendation is weak. In a perforated tumor, they've said you always go ahead, do a right hemicolectomy, and you should do a CRS HIPEC. And here the strength of recommendation is positive, strong positive, although the level of evidence is not very high. Of course, in the presence of metastatic disease, you go ahead and do a CRS and a hemicolectomy. Now, the similar guidelines are there for next slide, please. For a mucinous adenocarcinoma, again, in the absence of perforation, the consensus statement states you always should do a right hemicolectomy, and you could consider a CRS HIPEC, which the strength of recommendation is weak. In a perforated mucinous adenocarcinoma of the appendix, again, do a right hemicolectomy and do a CRS HIPEC. But like I showed you, these are not sacrosanct, this is not the holy grail. We do come across situations where we have to apply our mind and take decisions judiciously. So, should I stop now, or should I go on with one more advanced case you want me to discuss? If you have time, otherwise we can stop. Yeah.
So, I have a question to Aditi and Suman. So if a patient has quite a bulky disease, surgery may not be that option, quite a bulky peritoneal, and someone has said that perioperative chemotherapy is rather worse. So my question is that what is that bridge? If perioperative chemotherapy gives a worse survival, so where does PIPEC comes if it has to? And if that neoadjuvant chemotherapy with or without targeted therapy, I think no angiogenetic inhibitor, but yes, with anti-EGFR inhibitor, you're able to bring down that bulk either with systemic or with PIPEC. Does these things increase survival, not in a research setting, but yes, in an anecdotal setting for few patients? This may convert your surgery, and this PIPEC is actually a bridge to CRS HIPEC or not? And where does this stand in case of mucinous peritoneal, where PCI index is so high that operating upfront may not help that patient?
Can I answer that? As far as I am concerned, in case of mucinous appendiceal neoplasm with pseudomyxoma, there is no entity called inoperable. Everything is operable. You cannot completely resect. But that was one of my patients that I was planning to show. An incomplete resection or what we call a debulking is probably even better than giving palliative systemic chemotherapy in many patients. And it has been shown that even in signet ring cell cancers, you could go ahead and do a maximal debulking. The survival is not as good as you would expect in non-signet ring cell carcinomas, but it is still better than if you just not do anything. So I think
if I understand,
in mucinous adenocarcinomas, mucinous carcinoma peritoni, wherever possible, you go open inside, try to remove as much of tumor as possible. That is my philosophy.
Even in
Aditi,
I think I agree with that.
In man it helps.
I agree with that absolutely, because in high-grade tumors also, if you debulk, you do a good debulking, then it works well for some patients. There are some patients in whom it doesn't work well. The thing is that you have to see the performance status of the patient and
can I just show one slide?
And what about neoadjuvant PIPEC? His question was very pertinent. Do we use neoadjuvant PIPEC to that was your question, right?
I don't think with these extensive pseudomyxomas with large masses, the PIPEC would be very effective. Next. We don't have any data, but so far PIPEC works on miliary disease. So for a huge PMP, I would not do a PIPEC.
Next slide. Yeah. So there is evidence that even in a signet ring cell cancers, you can hope to improve the survival with surgery. It is not that signet ring cell means you should not operate at all. There is still a role for surgery, although the survival is not as good as in a non-signet ring cell.
Even if you can't resect all.
Yeah.
And
Next slide, please.
There's no role for pre-op chemotherapy. It's detrimental, in fact. So you provide post-operative chemotherapy in such patients.
Next slide. Next slide. Next slide. Next one. Yeah. So, see, these are patients who have undergone incomplete cytoreduction. And now they have identified some molecular markers and subdivided them into immune-enhanced and oncogene enhanced. The immune enhanced, especially the low grade, are supposed to have a survival which is quite good. You can see after incomplete cytoreduction, the median survival is around 7.7 years in the low grade. This is after incomplete cytoreduction. Whereas in the high grade, you still are able to achieve a median survival of 2.3 years in the immune enhanced subtype. Although it is not so good in the oncogene enhanced subtype. So there still is a role for incomplete cytoreduction in patients with even high-grade tumors where you are not able to achieve a thorough surgery that you would otherwise normally do for appendiceal malignancies.
Great.
I have not come across in a
so
mucinous...
let's say Signatring cell with Krukenberg.
Krukenberg is still considered as part of peritoneal disease.
So we go and resect.
Yeah. I mean, that is
Even
one of
if
the
we
common
can't
presentations. So you don't consider that as a visceral metastasis. Krukenberg is still a peritoneal disease.
So we are talking about low grade,
even Signatring cell, he says.
we are not talking about Signatring adenocarcinoma.
No, any adenocarcinomas.
Any adenocarcinoma.
Any adenocarcinomas. Yeah. From the appendix, probably not. Maybe if it is a colorectal type of adenocarcinoma where you really don't know whether the origin is from the colon or from the appendix, probably. But I have not come across appendix adenocarcinoma, Signatring cell carcinoma with metastasis outside the peritoneum.
We had one Signatring cell with lung metastasis.
Was who was, the diagnosis was neglected, and it was a mucinous adenocarcinoma. We gave chemo, the patient stabilized on chemo, and then did the surgery, and it came out to be a Signatring cell tumor. So I want to ask you, are you not more comfortable giving in neoadjuvant chemotherapy to when you have a proven Signatring cell adenocarcinoma? Personally, if it was unresectable disease, if it was resectable, I would go ahead with surgery, appendiceal.
Yeah, that was what I was doing earlier. But after I saw this, and many times, so that's what I want to ask the pathologist and the surgeons. Would you do a biopsy preoperatively in a patient with what is otherwise radiologically a pseudomyxoma? So then how do you know whether you want to give neoadjuvant chemotherapy?
I think somewhere along the line, trying to differentiate between what is solid and what is mucus on the preoperative imaging would help you some bit decide as to, this is the next question which I was actually going to ask, was which patient you would actually decide that this patient, I think it's better to give neoadjuvant chemotherapy.
See, that decision usually comes after you open up for a PMP, planning for a CRS HIPEC. You find that you are unable to do a complete CRS HIPEC. Not everybody will have a radiologist who is going to help as good as him. But you open up, you find that you are unable to do a complete CRS HIPEC. Then you do a biopsy from the peritoneum at that time. You close and then you give chemotherapy, hoping to take up the patient elsewhere. But what I do is, if I'm able to do at least a maximal tumor debulking, I do that, come out, and then you can give chemotherapy, because the extent of surgery is not going to change even after neoadjuvant chemotherapy. So having opened up the patient, make a big incision, you might as well finish whatever you can.
So that is where the question of being able to predict preoperatively, as Dr. Aditi also said in her presentation, that avoiding kind of a laparotomy in which you're just taking a biopsy and coming out, that's probably what is going to be.
So the other thing that I would like to point out is, when you see these enhancing areas, solid nodules, there are elements of high-grade disease. Secondly, it's very heterogeneous. A lot of times, where the biopsy is done, it just says grade 2 adenocarcinoma. When you say take out all the specimen and send it, it comes to be a Signatring cell. Yeah. So it's very heterogeneous disease. Pre-op biopsy just to confirm to the patient for these, for documentation purposes, it's okay, but it would not drastically change my management.
And in a patient who presents with abdominal distension with ascites, your chemotherapy is not going to take care of the mucinous ascites. So it is sort of a palliative procedure also for the patient, and as has been shown, you can even expect a good improvement in the survival when compared to chemotherapy alone.
What would be indications, definite indications for giving adjuvant chemo?
I think so we need to stop this, and we can have further discussion on appendix on the coffee. We'll move on. Thank you very much, sir, and thank you for a wonderful panel. Suman, I think so you are called there.